Oh my goodness. Welcome to the Diabetes Nerd Podcast. I am your host, Ginger Vieira. And with me today is my friend Tara Mayo and the one and only Dr. Robert Gabbay, Dr. Bob, as we might call him. Hello, Dr. Bob.
Hi, Ginger.
A lot of people might not realize how, I don't even know the words quite for it, how remarkable your background in endocrinology and how remarkable how much you've done, how much you're still doing, and just how much of your career you have devoted to supporting people with type 1 diabetes. Tell us.
That's very kind of you. I have been doing this for a long time, for decades, and I started as a laboratory researcher, a PhD in biochemistry, and trying to understand how insulin worked at the cellular level, and then went to medical school with the idea of doing research, but I ended up really loving caring for people with diabetes. So I did residency and fellowship and all that in endocrinology. And during the course of my career, I was really fortunate to have a number of leadership roles. The chief medical officer at the Joslin Diabetes Center here in Boston, where I
That's a
still
big deal. Yep.
that was a wonderful role, and could have been the role I would have kept all along. And I still see patients at Joslin, but then I had the even bigger opportunity for impact, and that was as chief scientific and medical officer for the American Diabetes Association.
Mm,
And so I've had a chance to do a lot of different things in the world of diabetes, and care for, whew, uh, yeah, probably by now thousands of people with diabetes, I'm going to
yes.
guess.
And you're also, I mean, you're involved. I'm not going to make you list all kinds of things, I promise, but you're involved in a lot of type 1 diabetes cure research and different therapies that are being developed. I mean, you're kind of
Yes,
everywhere.
yeah, the cell-based therapy and the promise of that is really exciting.
Yeah.
Uh, uh, Automated insulin delivery that could be fully closed loop, like meaning you don't have to bolus or do anything. It's like a driverless car. You just sort of
Yeah.
put it
Well,
on
can I
and it
ask you
does
a
it.
question about that? One of my biggest
Sure.
concerns about that,
Yeah.
okay,
Yeah.
is so I'm assuming we're talking about a dual hormone pump, right? That's
Uh,
treating lows too.
not Not necessarily, although that's one of the easier ways to do it. The dual hormone allows you to use both insulin and glucagon, and so you have a push-pull. Uh,
Mm-hmm.
you know, the challenge with insulin only is all you can do is shut off the insulin, but the insulin is
Yeah.
already, there. So, but there are models that are looking at predicting glucoses and therefore shutting off the insulin way earlier. And
Okay.
so
So that they
both
don't need
both could,
glucagon.
yeah, both could work. I would say, and it
So
sounds like you have concerns
I
about
have, yeah, I
glucagon.
have two now. Okay.
Yeah.
Well, so I have two.
Oh,
One
all
is
right.
the system, the single hormone system. It's
Yeah.
predicting, it's trying to prevent lows and predict, but insulin sticks around for so long that
Yeah.
even if this was the coolest algorithm ever, it's still, I'm if I get up and I go walk my dogs for 45 minutes, I still have all that insulin on board. It's too late for it to make a change.
Well, you're right that that's one of the challenges of this.
Okay.
Um, I think let's say there are two problems to solve, right? One is meals, and the other is exercise. Uh, for meals, that is, looks like it's reasonably solvable. I mean, we already
Mm-hmm.
have pumps that just say, small, medium, large carbohydrate meal,
Yeah.
which is already a big step forward from those in the audience that have been
Yeah.
counting actual grams of carbohydrate and using scales and all that. So that's a step in the right direction. Um, Activity would have to have lots of other input about your activity, which, again, they're wearables that can
Yeah.
capture all of that. So um,
Yeah.
that part will take a little bit longer.
I wonder if
But
you could, it'd be cool if you could be like, hey, I mean, this won't work for everybody because we do need spontaneity in our lives. But if you could be like, hey, Pump, I am going to walk my dogs at 1 p.m. So I want you to anticipate that and do your job.
Yeah. I think that to your point, I think that'll be the first step, right? It'll be
Yeah. Okay.
prompting that I'll be doing something, and it'll have a personalized algorithm, which I think we're
Hmm.
very close to having, that
Okay.
sort of knows when Ginger walks her dog. Uh,
Oh.
she's got a bunch of dogs, and they really move, and she's going to burn a lot, or she takes a very quiet stroll,
Right.
and be
Right.
able to calibrate for that.
Okay. All right. So my other concern with the dual hormone pump is we all know how hard it is to fine tune insulin doses. So if, and how critical it is, right? If you have a pump that's just always compensating for when you've gotten too much insulin by giving you glucagon, and then your liver is releasing stored sugar, I see a lot of weight gain going along with this.
I think if the algorithm is right, it really doesn't need to do a lot of glucagon. So the
Okay.
the natural physiology, and that's what we're trying to get back to. What the pancreas normally does is it has some insulin and some glucagon at all times, and that ratio gets adjusted based on for people without diabetes, based on their activity and their glucose and what they eat and all that kind of stuff. So you could very well imagine duplicating that in a similar way. And so, watching for weight gain, certainly would be one of the considerations. But we know that hypoglycemia is a big cause for weight gain, right? I mean, people
Yeah.
drop low and they,
And eat
understandably
everything.
have to
Yeah.
everything they can get their hands on, right? Right,
Yeah.
yeah, and
Yeah.
typically overdo it. So, if you could eliminate that, it might work out quite well.
Okay. All right. All right. I guess time will tell. I will not be one of the first people to sign up for this technology.
That's fine. Have you gotten in a driverless car yet?
No.
Well, see, there you go, right?
No,
Because there
I'm
is a
not
trust
a,
thing.
yeah,
Yeah,
I'm a late joiner. Is that one of those,
yeah.
is the people
She
that get right
also
in there?
is like a control freak, so she wants to have total
Ah, yes.
control
I was going to try
of
to bring
insulin
that up
and driving.
gently.
Yeah.
Yes, I was going to bring that up gently. So I think that has been one of the challenges with automated insulin delivery, even with the current, things that we have on the market, is I've had a number of patients that, find it difficult. They have it, and then I look and it's like, oh, you only use auto mode like, 20 or 30%
Mm.
of the time. And they're
Oh.
like, yeah,. I'm not just so sure about it.
Mm.
Um, Usually, though, with experience, you get more comfortable. And I
Yeah.
really liken it to a driverless car, like it was in San Francisco. And in Waymo, they're driverless cars. When you first get in, it's really weird and you're really not sure. And they're going, and but then, 10, 15 minutes in, you stop watching and you're
Mm.
back in conversation and you realize, yeah, no,
Mm.
it seems to work pretty well.
I get,
So
it's a big deal for me to just use cruise control on like even a 10-hour drive to
you'll
Virginia.
be a late adopter then, Ginger.
Late
Yes.
adopter for sure. Okay, so what we really want to pick your brain about is GLP-1s and SGLT-2s in people with type 1 diabetes. And we have about 1,000 questions. So I take a microdose. I started at 0.25 and I I weigh
You're talking
basically the
about
same of
a
Ozempic.
GLP-1. Yeah.
Yeah, I take
Okay.
a
Gotcha.
0.25 of semaglutide. I went up to zero point 0.5 at one point, but I could not tolerate that. Any even just a banana and peanut butter, I'd eat it and my stomach would just hurt so much. And then I also was just having too many lows, and it didn't seem like there was any way to reduce my insulin in a way that made things manageable. But 0.25 was great. It eliminated food noise. It just calmed down my appetite. I felt full. I just wasn't constantly thinking about food and resisting the urge to eat when I didn't need to eat. And also, just post meal blood sugar spikes, delayed digestion, all of the above. It decreased my long acting dose by 20, 30%. So that's my snapshot. I eventually went down to 0.15 by hacking my pen with a syringe. And I just figure less is more. I want to use and depend on this as little as possible. Okay, so that's my intro. I know. Okay.
Well, I'll say, some of the things that you talked about are common. So side effect is certainly nausea. Some people get it, at a very low dose. Most people, if you gradually go up, are able to tolerate a larger dose. But everybody's different. And that's one of the interesting things about these medications is people's response really varies a lot. So
Mm-hmm.
if you look at the clinical trials, they'll show an outcome like a curve, but the error bars, the variation is really quite large. And so
Mm.
people respond differently. So
Okay.
it's key to figure out what the right dose is for an individual. Uh, the other thing that you mentioned that also is common, and I've seen a lot, is the food noise issue. I'd say for people with type 1 diabetes, the biggest advantage, yes, it can lower A1C and does, maybe about zero point 0.3 to zero point 0.5. It increases time in range. This is based on, randomized controlled trial results that were presented just recently at the American Diabetes Association. Um, but the thing that really is the game changer for most people with type 1 is they're just not thinking about food so much. And that had been a big issue for them in the past. And that effect seems to be at a lower dose. Like you don't need to get,
Yeah.
the full effect and the weight loss, sort of aspect of it. So,
Yeah.
those are common things. Uh, there was something at the end there which I was like making a face over.
Oh.
One of your
Oh,
other
I said
things.
less is more, and you made a
Oh,
face
less
about
is
that.
more. Yeah, I don't believe that that's, I think getting the therapeutic dose is what's
Mm.
important, right? And
Okay.
whatever that might be for an individual, that's what
Yep.
it is. Um,
Okay.
Also mindful that although one third of people with type 1 diabetes also live with obesity, and for them, weight loss is an important issue. For
Yes.
people that don't, then yes, a lower dose so that you're not losing too much weight is important.
Right. Yes. And I have heard, and I'd love to hear if you've heard this too. I heard this from a nurse practitioner who's also a CDE, who also has type 1. He said that he finds that even people with type 1 living with obesity need lower doses and are more sensitive to it than people with type 2.
That I haven't heard per se.
Okay.
I would say that uh, the individual in the study that wasn't necessarily the case.
Okay.
Uh, One other thing to point out, which you mentioned, and I think is important for people to keep in mind, is it will lower your glucose levels, and so you need to back down on your insulin and being
Mm-hmm.
careful to do that. And that's largely why it was not approved officially by the FDA for type 1 diabetes, because of the concern for hypoglycemia. But again, any medication that makes you, that has you lose weight or makes you more sensitive or eats less, you're going to need to change your insulin dose. And,
Yeah. So it's so silly to me that, I mean,
yeah,
once, because it's not like it's random. It's like once you
right.
reestablish your new doses, now you're on less insulin, which actually
Yeah,
decreases my risk of hypoglycemia
yeah.
because I need less insulin now.
And you're right that it is gradual. And so it's not like, one day you need, this amount, and then the next day you need half as
Right.
much insulin. No, it's gradual, because typically this medication is titrated month by month. So it's a very long acting drug. You take it weekly, and so there's plenty of time to make the adjustments. Um,
Yeah.
for folks that have been around for a while, there used to be a medication, Simlin, which was
Mm-hmm.
an amylin analog, which sort of, in the early days, it helped to lose weight. It stabilized blood glucoses a bit. It helped a little bit with appetite, and that got approved, but with a warning about hypoglycemia, and cutting the insulin dose a lot and then gradually going up. So it's totally doable. It just
Yeah.
requires attention, like
And so
everything
for
else in type 1
listeners,
diabetes.
Simlin is a GLP-1. It was kind of one of the first, but right? No,
No,
not quite.
it's an amylin analog.
Oh, okay. It doesn't count. Okay. And
Yeah,
but
so
it
it
had to be
works in a
taken
different
because
way.
I've had people reach out and say, "Oh, I tried Simlin. It was terrible. How's this any better?" And I'm like, "No,
Yeah,
it's completely different."
completely different. Yeah,
Yeah.
yeah. That drug just never really, I had some patients with it, but yeah, it never really. The nausea was a significant issue, more so than GLP-1s. The weight loss wasn't anywhere close. It didn't have a lot of. There was no discussion about food noise, and you had to take
Mm.
it 3 times a day as an
Yeah. Every
injection.
time
So
you
it's,
eat, right?
yeah, every time you eat. So it's
So
sort of
that means
like,
it's also like it's on this roller coaster of efficacy.
yeah, yeah. Interestingly, the concept of amylin has made a comeback, and now there are a number of new amylin type medications built on that mechanism that are
Oh,
once weekly injections, and one that's combined with semaglutide that probably will come to the cargo sense, that'll probably come to the market, in the next year or two.
interesting. So
So
better,
amylin
new and
amylin's making a
improved
comeback.
versions.
New and improved,
Mm,
right, exactly.
okay.
They fiddled with the molecule in a lot of ways over the last, 15 years to figure out how to get around the long actingness and, all
Mm-hmm.
the other issues.
Interesting. Okay. It'd be kind of, this is silly, but what comes to my mind when I think of something like amylin that was such a failure, really, back in the day, and if only it had today's science and technology. Imagine if you took Arnold Schwarzenegger, bodybuilder, not that he was a failure, heaven forbid, but from his generation, and then you put him into bodybuilding today at that same age, and now he's got a whole different set of tools and drugs and all the things. He'd look like a completely different guy.
Interesting.
So,
So the interesting story about amylin is, so there was a company, as you may know, named Amylin. Um, they were on the verge of bankruptcy, and were going to shut down, and they had two drugs, uh, one Simlin, and the other the first GLP-1.
oh,
And within weeks of running out of money, both got approved by the FDA, and you know,
oh,
that was the beginning of the GLP-1s 20 years ago.
wow. Okay.
Yeah.
Wow. How funny.
So,
Okay. So, what I have seen a couple friends with type 1 take a GLP-1 to prepare for a wedding, take, they get dosed up to the therapeutic dose. So they're on
for the
like
weight loss,
2.5, right?
yes.
Yeah. And they're sick all the time. And they are puking after meals. They have no appetite. They're eating just crackers all day. They lose the weight, right, for their wedding. They feel glamorous on wedding day. And then after the wedding, well, they either A, want to start preparing for pregnancy, or they just want to be able to eat food like a human again. And I want to mention again for listeners, like this is on the 2.5 dose, not the 0.25. And they go off their GLP-1. Both of them gained a lot of weight. I mean, like 30, 40 pounds within a few months. Can you tell
Well,
us why that? Yeah.
first I'm going to guess that they lost 30 pounds, and what they
Yes.
did is they went back to where they started.
Yes.
That's true of this class of drugs, but honestly, it's true of most classes of drugs. So if you think of weight management and obesity as a chronic disease, uh, when you treat it, it works. If you take a blood pressure medicine and your blood pressure comes down and it's all great, well, when you stop that blood pressure medicine, guess what happens to your blood pressure? Goes right back up.
Yeah.
Same thing with a weight medication. You're going to go back to where you were, and that's been the experience.
So
So
I think that's what's hard for people to grasp, because in weight loss, we think, well, we get our weight down and then we can maintain that. Why can't you maintain weight loss that was fueled by a GLP-1?
I would say it's the same reason that most people can't lose 15% or 20% of their weight through lifestyle, right? There's a set point that your body wants to get you to. And these drugs and diet and exercise do not change that set point. So the push is always going to be to go back up to where that your body thinks its set point is. So interestingly, when people lose weight, and this is studies that were done in the past before any of these medicines were around, uh, when you lose weight, your body's metabolism changes in an adaptation to have you regain the weight. Um, so it's trying to get you to what it thinks is the right weight. Now,
Wow.
if we could change the set point, yeah, that would be the real answer, but no one has figured out how to do that.
And then, okay, so then in type 1, we also know that we kind of overproduce glucose from our liver. So that plays a big role in the weight loss, right? Is we're producing less sugar, and which means we need less insulin, which means there's less sugar we're storing as body fat. I referred to it myself. I had probably like 3 or 4 pounds I could never really get to budge prior to a GLP-1 unless I underate, which wasn't sustainable, right? Like if I just had a stressful week and I didn't eat a lot, I'd notice those 3 or 4 pounds kind of dwindled away, but then I'd go back to my normal diet, and I'm very active and eat very healthy. And so I referred to those 3 or 4 pounds as my insulin chub. It was like the extra insulin I needed to deal with the extra sugar from my liver. How logical does that sound to your brain?
Uh, I'm not sure it's the liver glucose per se. So let's just back up for the audience that may be not familiar with how GLP-1s work. So they have three main effects. Uh, One is they slow down the emptying of your stomach, so you feel more full and you eat less. Uh, they have effects on the brain in terms of appetite and suppressing the appetite and the food noise and those types of things. And they stimulate insulin production, which in people with type 1 diabetes, it doesn't do that because they don't have the cells, but it lowers glucagon. And so that's where the liver thing sort of fits in. Uh, uh, some people with type 1 diabetes continue to make glucagon, and that glucagon brings glucose out of the liver. So, yes, I'm not sure it's the liver per se, uh, but you're right that people typically have uh, a few pounds that they just struggle to be able to lose. Uh, whether uh, needing a higher insulin dose before GLP-1 versus after is part of it, or frankly, people are generally eating a lot less
Yeah.
because they're
But
feeling
I'm
more
very
full,
conscious of how
and that
much I
and that
eat.
works. Yeah.
Yeah, yeah. I mean, I know those 3 or 4 pounds aren't just related to calories, because I'm very conscious of. But so yeah, it's interesting that little amount that is now I don't have to work as hard to keep those 3 pounds at bay. It just I can just make my weight is much more stable. It doesn't go up three, down three, up three, down three. I don't know. Okay, I have another GLP-1 question for you. You ready? So, I of course get questions all the time from people when I talk about it on social media about the research related to eye disease and Ozempic.
Yeah,
Yeah.
it's unfortunate that that has been sort of misinterpreted. It doesn't cause worsening eye disease. That's not an issue. Uh,
Okay.
what explains the times where that's been seen uh, is we know that people that have active eye disease and you rapidly lower their blood glucose, their eye disease can get worse. So we see
Oh.
that, for example, in pregnancy when women all of a sudden start, really
Mm.
being much more diligent about their blood glucose, and that's why screening, having an eye screening before, ideally
Yeah.
before pregnancy or right at the time of pregnancy, is important. We see that with people that are treated with any other diabetes medication, people with type 2 treated with any other diabetes medication, and you lower their A1C rapidly, and they have active eye disease. So uh,
Mm.
when they've looked at this, just looking at 1,000 people, with and without the drug, there's no increase in eye disease. So
Okay. Thank
I
you.
wouldn't worry about that. And I would say, like everybody else with diabetes, a yearly eye exam to catch any active disease is very important.
Absolutely. Like extremely critical. Yes. Can't spot
Yeah,
it
I mean,
with that exam.
yeah, you would not know, and by the time you know, it's getting pretty late.
Way too late.
And the other thing about eye disease in particular is, um, it's something that, like, nobody should lose their eyesight anymore because of diabetes. Like, we know
Mm.
how to stop that,
Yeah.
and it's just a matter of catching it early and treating it. And whereas the other complications are more complicated, this one, like, they figured out what to do. It's just that
Mm.
only 60% of people with diabetes get a yearly eye exam. So
Ah,
a lot of people are missing out. And of
okay.
course, there are challenges, and it's not simple, et cetera, et cetera. But yeah,
Right. Yeah.
yeah,
There's some people that simply don't have access to eye
right.
care, period. Right.
Exactly, exactly.
Okay.
Right, right. Yeah. And even retinal scans, which are becoming more common and affordable, are another way to do this. And,
Yeah.
the hope is that those, you know, lower the costs and increase the access. They can be in a pharmacy or anywhere else, same way you get a blood pressure check, at a CVS. In theory, you could have an eye exam done there as
Sure.
well.
Okay. Okay. I have
I
another.
have a
Oh,
question
go
here
ahead, Tara.
as we're talking about this. I'm curious about your thoughts on, or your take on off-label use of GLP-1s for people
I was
without
gonna ask that.
diabetes or obesity.
Without diabetes or obesity. So first of all, use for type 1 is off-label.
Off label.
That
Yeah.
said,
Yes, yes.
yeah, right, right. Just, for the legal scholars in the audience. Uh, uh, and and so people that are of normal weight, that's what I'm wondering if you're asking, and using it to
Or like
just
a
lose
little,
a
I think
little
she
bit
means
more.
like, yeah, a little bit, like
A
15
little
They're
bit,
at a
pounds.
but not
healthy
quite
rate,
obese.
but yeah, maybe I'll say they're at a healthy weight, but maybe not cosmetically preferred weight by their view.
Perfect. Yes.
Yeah, I first, it would work, and again, it's being used, quite commonly in that. I think there was a joke at the Oscars of the number of people in the audience that were all on a GLP-1.
Hmm.
Uh, uh, you know, the caveat is that medications are studied in a group of individuals to know that they're safe. These have not been studied in this population, and certainly malnutrition is a concern. Um, and maybe that allows me to just bring up one other issue that people don't think about or talk about enough, and that's the importance of protein intake.
Mm.
Uh, you know, we know that these drugs can cause some muscle loss. Typically any weight loss, you lose some fat and some muscle. Uh, because people are eating a lot less, it's easy for them not to get enough protein in their diet. And it's particularly true for older individuals who need, higher amounts, 1.5 grams per kilogram body weight. And even
Last night at dinner,
younger
she and I
people.
were literally adding up how much protein her grandmother gets versus how much we
Yeah,
get.
it's
Yeah,
hard, right? It's not, unless someone is a big carnivore, in which case, okay, you typically will get your protein. If you're not, you've really got to think about how to get enough protein.
it's a lot of protein.
And so that can, prevent the muscle loss, along with strength training is the
Yeah,
other thing that is important. So those two, really, for anybody that's on a GLP-1, they should be thinking about.
yeah. I get asked that a lot. Oh, what about your? And it's like I lift weights many times a week. I've lost no muscle. So,
There
yeah,
you go.
it's
Very
not
good.
quite a
You're a good
concern.
role model.
Right. Um, I have one more question about. Oh, okay. So I don't know if you're even allowed to really give recommendations here, but I know lots of ways people with type 1 have been getting GLP-1 prescriptions approved by their insurance. Is that anything you're comfortable speaking on?
I can speak about my colleagues.
Yes, let's do that. Let's
Um,
throw them
so
under the bus.
yeah, yeah. Well, uh, sometimes you just make the argument for reasons outside of type 1, for
Mm,
cardiovascular risk reduction, for kidney disease, all of those, for liver disease. Those are other indications, and there will be more sleep apnea and, a whole host of other things. So that's one strategy to argue that it's not because of their diabetes, but it's because of these other reasons.
mm,
Um, I would say that if you look in patients' charts, particularly in electronic health records, there are lots of diagnoses. Like, I don't know if you get your sort of visits printed out, but if your provider's using something like Epic, often there's like a whole host of things. And every once in a
mm,
while, type 2 diabetes slips in there by mistake.
okay. Yeah.
Yeah. So
Yes. And it may be impaired insulin resistance or impaired glucose. Type 2
yes, yes.
diabetes just pops in.
It
Yeah.
all depends on, what the payers are looking for. The
Mm-hmm.
hope is that the recent study that was, presented and published in the New England Journal of Medicine of the use of semaglutide in type 1 diabetes will lead to better coverage.
Yeah.
And coverage of, these medications is a big issue beyond just those with type 1 diabetes.
Yes,
Obviously,
definitely.
that's a very big problem.
Yeah. And anytime something is new, I mean, CGMs, we used to have to jump through hoops to get a CGM. I used to produce, I remember having to create 3 months worth of blood sugar levels, and I realized they weren't actually like nobody's looking and no one can tell this even came from my meter. So I would just make 3 months worth in a spreadsheet.
And then you
And
had to show that
yeah.
it was 4 times a day testing.
Yeah,
I,
I'd
I
put some
do think
crazy
that,
numbers in there
yeah,
too. I'd put
yeah.
like 440 so they could see how badly I needed a CGM.
And as providers, we would have to check off these things. Blood glucoses are fluctuating, between
Mm-hmm.
this range and that range. Um, That said, these medications are considerably more expensive than,
Yes.
anything else
Yes.
we've, used at this widespread a level. And so that's going to make it trickier. And the hope is, the pipeline is huge. I was just at an
Mm.
obesity conference here in Boston, and there are 150 different medications in clinical trials currently. So
Whoa.
there's a huge pipeline. Um, of course, only a subset of them end up getting approved and getting all the way
Mm-hmm.
through. Um, and what will they price it at? Obviously we'll have to wait
But
and see,
hopefully
but
that
there's
brings
hope.
down the overall cost and
That
increases
that that
access.
would that would be the hope.
Okay.
Although your listeners will remember that that didn't exactly work out for insulin for a lot of years.
No. Yeah, because
right? There
Greed
were
is
new insulins,
good.
so the cost didn't really go down
Right,
until
right.
it really had to,
Yeah,
so
until they were
we'll see.
forcing people's
Yeah,
foot on their
yeah,
throat, basically.
right,
Yeah.
yeah, yeah, yeah.
Okay,
And it
so
helped that
let's,
they, yeah. Anyhow, all right.
yeah, that's a hot mess. We can't even
Yeah,
start trying to
yes,
dig into
right,
insulin
yes, yes,
pricing.
yes, yes,
I don't want to
yes,
get attacked for the rest of the month.
yes.
You can never say it all correctly. We'll say something wrong. Um,
Probably already have.
so
Yeah.
yeah, I'm sure every day. So let's spend a few minutes just on SGLT2s, which is far less exciting, but it still comes up. There's some people that have such great experiences with an SGLT2, which for listeners basically leads you to excrete some glucose through your urine. It prevents the absorption of glucose from what you eat into your bloodstream, results in lower blood sugars, a teeny bit of weight loss. The I also see, because I've made videos about it and I get comments, right, all the time. So I have people who love their SGLT2 and then people who are in the hospital after 1 week on an SGLT2, even with type 2 versus type 1, right? And then so tell us what you want to tell us about
Ah,
SGLT2s.
well, I think you did a nice job of summarizing, what it is. Uh, the weight loss that you got with it before the days of GLP-1s was like a nice thing.
Yeah.
Now that's nothing, right? Like,
Mm-hmm.
it's we dismiss it. I I would say what really is special about these medications is what they do for people with chronic kidney disease or with heart failure.
Okay.
They're really very effective at preventing the progression of chronic kidney disease and treating heart failure. So much so that they're being used outside of people with diabetes. So it was discovered
Mm.
to be beneficial for people with diabetes, but now we realize everybody. And so cardiologists are using these medications pretty much for anybody with heart failure.
Wow.
So
Okay.
if you have those issues, then absolutely these are drugs to consider. And generally, they, are covered even for people with type 1 diabetes. Uh, the problem, and the reason people end up in the hospital is it increases the chance of having diabetic ketoacidosis, DKA, 3 to 8 fold. So it really
Mm-hmm.
increases the risk. And you can even get DKA when your glucose is not that high. And that's something that really
Yeah.
is very unexpected and people can run into trouble. So it's weighing the risk and the benefit of that. And so the risk of DKA seems to be dose dependent. The higher
Okay.
the dose, the more likely it happens, and that's why when they're used, typically for people with type 1, usually on the lower end, and they're approved in Europe, two of them for use in people with type 1 diabetes, specifically at the low dose, because
Okay.
again, trying to lower that risk. So I think they have a place used cautiously. And if we soon have continuous ketone monitoring on the market, well, then
That
that
would be
would
a little
make it a
better.
lot safer. You could
Yeah.
you could catch this before it becomes a problem. So
Right.
stay tuned, and that's
I took
probably you know within a year or so,
Oh, okay. Yeah. I
two at
took
the most.
some for 1 week I took an SGLT2. It was Invokana and I could not stand how thirsty I was, how often I had to pee. It was just so annoying.
And it's a diuretic. I mean,
Yeah.
it literally, so yeah, the other thing to caution around is increased risk of urinary tract infections
Yeah, and yeast
because of all that
infections.
glucose in the
Yeah.
urine
Is
and yeast
that
infections.
lesser
Right.
of a problem in people without diabetes who are taking these for heart and kidney because they don't have as much glucose in their bloodstream, supposedly?
But it still dumps glucose, and they still
Okay.
have that risk. So it's
Okay.
and much more common in women than in men, but
Right.
it's still a consideration. Yeah.
Okay. Yeah. It's and I mean I think it's really even more so than GLP-1s, where some people just don't have a good experience. But it seems like really from one person to the next, good or terrible experience with an SGLT2.
Yeah, I would say if someone's been hospitalized for heart failure, yeah, you you you're
You
going to
should
want to
take
be
it.
on that. Think about it.
Okay.
Yeah, right.
Okay.
And monitoring because heart failure is quite significant, right? I mean,
Mm.
people that are hospitalized for heart failure, their chance of being hospitalized again is extremely high, almost like 50%.
Mm.
And so and it's been shown to prevent hospitalizations for heart failure. So
Oh, wow.
that's a big deal. Again, with heart failure, but for general people with type 1, yeah, it's it's hard to argue why to do it,
Okay. Yeah.
except for
It's
special
more
circumstances.
risky. Yeah.
More risky, yeah, yeah.
Okay. Well, thank you, Dr. Bob. We have definitely learned a lot. I feel like you answered a lot of our burning questions on
Yeah, I
GLP-1s.
have one last question.
Let's hear it.
Like,
Please.
what excites you the most about the future of the GLP-1 medications?
Oh, the GLP-1s. It's hard to put my finger on one. I would say, you know, outside of people with type 1, oral GLP-1, I think
Mm.
is exciting because people with type 1 diabetes are not so worried about doing a weekly injection.
Oh,
It's not a big deal, right?
yeah.
Um, and still, we've got lots of people that are taking it. But if you could just take it as a tablet, that could open it. Again, access. What will that be? It's for better or worse, it's a lot cheaper to manufacture than
Oh,
peptides are. Those are
okay.
notoriously expensive. So I think that's one, and then I think uh, the the possibility of uh, solving the muscle problem and the muscle loss.
Mm.
Particularly, it's interesting. You measure it; it's clearly there in clinical trials. Uh, it's unusual for patients to complain about it, um, but we know that it may. We know that certainly for the elderly, it can be a significant concern.
Mm.
Really, muscle mass is very important, and they tend to lose it as they get older. So, medications that could prevent that from happening in combination, and those are also close and were just presented at the American Diabetes Association meeting. So,
Is
yeah,
this a different type of GLP-1 that wouldn't induce muscle loss, or it's a medication you take in addition?
in addition. In
Oh,
addition, yeah,
okay.
that's largely what it's been.
Interesting.
That they
Okay.
stimulate muscle uh,
Oh,
uh, uh, you know, So yeah, I mean, you were giving the example of Arnold
I was gonna
Schwarzenegger.
say, sounds relevant.
I was just going to say, anybody in that world, Ginger and I came from the gym
Yeah.
background. If they hear
Oh,
GLP-1s and then muscle growth, they're going to be all
yeah,
over both of them.
yeah,
Yeah.
right, exactly,
That's gonna open a
right.
whole
So
nother can of worms.
that will be a yes, right. I think so. And they're out there. They're
Hmm.
in late clinical trials. So
Okay.
stay
Yeah, they're
tuned.
also out there probably already on the black market where
Yes, who knows?
bodybuilders
Right.
have been
Yeah.
taking them
Yeah.
for a long time.
Yes. Yes.
Okay, interesting. All right. Well, thank you so much. It has it's always a pleasure to have your time and expertise, and we certainly don't take it for granted. So thank you.
Thank you.
Thank you both, and thank you for all of the valuable information you provide people with diabetes. I know that
Thank you.
lots of people tune into you, and getting credible information is so important. So thank you.
We're trying. Thank you.